So we have the wonderful privilege of having Dr. Aaron Wolf share with us how he incorporates the Ovid's HOA technology in his office, how he streamlines the process in his office, and overall how he maximizes the ROI. Dr. Aaron Wolf practices in Austin, Texas, and is the owner of the Austin Optometry Group, specializes in all things contact lenses, and is a fellow of the AAO, fellow of the Scleral Lens Education Society, soon to be fellow of the International Academy of Ortho-K and Myopia Control. All right, so without further ado, Dr. Aaron Wolf, if you can share your presentation with us.
Okay, thanks, Jenny. So I did put together some slides on ROI, but because this is kind of like a private webinar for people who are already Ovid users, I'm really more interested in kind of getting into the discussion component so we can try to figure out, okay, what's really working for other people really well, and if it's not working, maybe why that is. And everybody that's on the call is basically already an Ovid's person. So there's going to be a lot of value if we do kind of open it up for that discussion. I'm interested in that. So real quick, ROI, we all know what ROI is, return on investment. When I kind of think about return on investment outside of a financial standpoint, it's really more or less like, okay, like why would I pursue this, this instrument, or maybe this like specialty or the service, whatever it is, essentially, right? So you ultimately want to get back out of something more than you put into it. And that's really kind of a sort of thinking about it. That's kind of true for pretty much everything, right? So outside of, instrumentation and scleral lenses, we're always trying to essentially get more back than what we put into it. So we got to be a little bit careful, I guess, about what we're putting into it, or make sure that we're maximizing what we're getting back. So there is actually a formula for ROI. You can essentially, you have to kind of chew on this a little bit, what's important to you, and you can talk to your consultant or CPA regarding like financial ROI. But when I think about ROI, it's really not always financial. It does feed back into like what is the ultimate benefit or purpose that I'm doing this. So these are some examples of some like, profit and costs, that I could kind of think of. And not obviously the financial payment would be the profit. But outside of that, there's opportunities for, retail products, you start to fit more and more scleral lenses. There's, sterile salines you can retail out of your office. There's, eye drops, there's, cleaning products and HydroPay Boost products. Outside of the income, or at least the monetary income, we are sometimes, I guess we almost get not jaded, but accustomed to providing this really amazing vision, this restoring vision for some of these patients. But a lot of the patients that are going to need, higher order aberration correction, they're irregular cornea patients for the most part. And sometimes, it's really good to take a step back and just realize what it is that we're actually providing for these patients. We talked about this in a call, I think, a few months ago about, empathy and, I guess just an understanding, right? So ROI and the ability to measure that quantitatively, it's really, no pun intended, it's really kind of eye-opening to see, how somebody's vision can be just so impacted through something like ROI, despite really sometimes what acuities can be. So there's a lot to be gained just from an empathy standpoint. Professionally, of course, you can market this to your colleagues in your area. You can market this to, potential referral sources. There's, opportunities for posters at, conferences and webinars and things like that. So there's a lot of growth there. Personal growth, staff growth, that's one that really can't be understated either, because, if your optometry office is really just like any other optometry office, then it can be difficult to sometimes keep staff. But if your optometry office is special or different in some way, outside of just salary, that's a lot of what certain staff are looking for, right? They're looking for opportunities for their own personal growth, and they're looking for something interesting. So this does really offer that, and helps build that identity for the entire practice. In my office, we have a mission statement. It's basically incorporates a couple of different aspects of care, but one of those aspects is essentially technology and kind of staying on the leading edge of technology, but also just specialty care. And then as far as Relationships, that's something that can also be a little bit understated, right? So when you go to conferences over enough time, and you're doing kind of more specialty work, there's a lot of reward in just kind of knowing people that are in this with you, whether they're on the lens side, the topography, profilometry, tomography side. It's really a small family, which I think most of us have I'm sure all of us have experienced, but it's nice when you kind of know most of that family. Okay, so these are some of the challenges. I think some of the biggest challenges with HOA. One is going to be, potentially a lack of interest, and I don't think that's like the patients don't find it interesting. Largely, they just don't know this technology exists. They know that they experience HOAs, especially once explain what we mean by HOAs. But it's relatively new technology as far as a solution. It's very new, right? And then Obits, I'm quite sure, is still the only ones approved to do this right now, at least in the U.S. The solution for that is essentially just to discuss it more. I usually think of HOAs really like orthokeratology. There's some other surfaces, maybe some dry surfaces as well, but multifocal implants, IOLs, those would be kind of something similar. But generally I just do a lot of orthokeratology in my practice, so I really kind of view them similarly. Patients don't know this technology exists unless you mention it and kind of plant the seed. That doesn't mean that they're going to say yes. Like, the fact is most of them are going to say no, but it is up to you to kind of plant that seed and year in and year out, see if that grows. The other main problem is going to be just an increased number of visits, right? So, anytime you do something that's a little bit more specialized from an optics standpoint, there could be a little bit more fine tuning of that. So the solution is to decrease the number of visits. So when we decrease the number of visits, we'll talk a little bit about, do you yourself need to be doing all those visits, and how much maybe can be delegated? Where can it be streamlined? The visits can be longer. So how can we, shorten that visit, right? That's the solution there. The main issue, and Jenny was kind of mentioning this a little bit about, decentration. Well, HOAs they're super, super precise, right? So if your lens is going to decenter or rotate, it's really, really tough to have good results that way. We'll talk a little about instrumentation that may be helpful with, rotational stability, whether that's, scleral profilometry or really even impression lenses. But that's going to be a huge component to success here. And then, sometimes at the end of it, you just feel like you didn't make enough money. You didn't make enough money that was worth it. So, there's ways around that. You can either charge more for what you're doing. You could charge the same, but do it faster. You could charge for different things, like outside of just the overall service of the lens. You can charge for the aberrometry itself. So there's a number of things that you can do to increase your billing, but ultimately if you feel like you're not getting paid enough, well, we got to find a way to get paid more. All right, so major things that essentially affect success or failure with the Ovitz lenses and the Ovitz technology, essentially, selecting the right candidates. And this is, again, true for pretty much anything that we do, even sometimes like progressive glasses. I mean, as simple as just glasses sometimes. Like if you don't have the right candidate, like it's just sometimes not going to work out. And it only gets more complicated, with custom HOA optics. Aberrometry workflow, I'm a big proponent of doing aberrometry, on everybody, not just, for these scleral lens patients, and trying to manage that workflow. Fitting tips, we'll touch on it, but, Jenny did a great job kind of just briefly mentioning that. And, these slides are not by any means intended to teach anybody how to fit a scleral lens, which everybody here knows how to do very well. Efficiency with the actual Ovitz HOA lens correction as opposed to like, the aperometer. And then briefly some opportunities as far as some billing. Candidate selection, right? So again, candidate selection is pretty much everything in most of what we do. Who's a good candidate? Generally speaking, I kind of like to think about 0.3 microns or up. Somebody might have some symptoms of their HOAs. Particularly when I'm thinking of individual coefficients, 0.2 or less is like very rarely is somebody really going to complain about that. 0.3 is like probably still not too bad. 0.4 is maybe possibly a little annoying. 0.5 to 6 is like probably when they are symptomatic. And of course, above 0.6 is that's way up there. So I usually describe, HOA RMS as kind of like a total score because patients, I really love the plot, the Zernicke plot, which is for anybody that hasn't yet gotten their OVITs. It's basically just individual HOAs. You can see a quantifiable amount of each individual coefficient. That's most valuable to me, but patients kind of look at it, with their head tilted. So that kind of summary page is kind of nice. I do really want to ask them if it's bothersome because, it doesn't really matter. Maybe they have a lot of HOAs in one eye, but it's, their non-dominant eye perhaps, and in their dominant eye, it's not bad. So don't go just based on HOA quantitative data. It really does have to be, bothersome for somebody to really get much out of this. HOAs that are caused by things that are going to be more stable, which is basically like, your different ectasias, keratoconus, corneal dystrophies, corneal grafts, various refractive surgeries, essentially anything that's not really going to change from day in and day out. I want to jump ahead over to the other side because I do think it's easier just to kind of counter this with the bad candidates. So, as we mentioned, bad candidates are going to be people who just aren't bothered by this. So if they're basically not bothered by it, you just save your breath and essentially just move on. It's good technology to have for yourself, but they're not likely to really benefit much from this. Things that are temporary, right? So if somebody's got a PSC cataract, they could be very symptomatic of other HOAs. PCO after cataract surgery, very symptomatic, but those things can be fixed, right? So there's other options there. Severe dry eye, that'll impact you a little bit, but that's kind of a separate thing. You're really gonna have to tackle the dry eye, anyways. So I'd really kind of go all in on your dry eye treatment as much as you can first. I had a patient recently who had a kind of partially kind of subluxated lens. That's something that it was causing some issues, but I wouldn't go this route right now because I don't know at what point something may be done about that surgically or not. So, there's a fair amount of investment into these lenses here. So, and they could potentially have them for multiple years, if they take good care of them. So you really want something that's a little more stable. Opacities is a little bit of a, I guess, controversial topic, here within the group. I think the OVIT's approach is generally, corneal opacities are not ideal candidates, but I've had really great success with opacities, and sometimes ones that I thought I certainly would not. I don't think that it rules them out, but certainly if it's a very dense opacity or just smack dab in the middle in dense, then yeah, this isn't going to make any sizable difference for them. Retinal disease, that's going to be a factor too, right? Because, even if their HOAs aren't entirely from, maybe they are like ectatic or keratoconic or something like that, and they're going to get some HOAs, but at the same time, if they've got, significant, macular degeneration or central serous retinopathy or something, then they're also not going to get much out of this. So you got to remember, as much as we're focused on the anterior segment, sometimes we really got to be looking at the retina carefully. Then there's some personality traits, right? So some of our patients, as they are, pretty reasonable people. They do pretty normal kind of reasonable stuff day to day, and we've got some people that aren't, right? And sometimes the people that aren't, they will trick you into thinking that they are, and then weeks down the road or months down the road, you realize that this person really just didn't have kind of reasonable expectations for what success was going to look like. So you want to try to iron that out. Unreasonable visual demands, that one, it depends, as Felix and Nick and Jenny know, I've got a patient who's it's really a cool case, but he's a Olympic pistol shooter, competitive Olympic pistol shooter, and his vision demands are just very extreme, very precise. And, we were doing this for him because we're trying to get every competitive advantage that we possibly can, right? So it can be worth it for sure. And he's having great results, but because he's having such great results and because his expectations, or demand is so precise, it's kind of like we're just squeezing out every last little micron out of his HOAs, and there is a kind of a point of diminishing returns, really. the HOA component of scleral lenses is not covered by insurance. It's a self-pay responsibility. It is an upgrade ultimately, right? Above and beyond what normal optics are going to include. So you do want patients to understand that they will be responsible for that. And that's up to you to really be clear about that. But those surprises later or kickback later, if something's maybe if they weren't a good candidate or didn't have good outcomes for whatever reason, you don't want that coming back later and being a point of conflict. Scleral asymmetry, this is really in regards to, scleral profilometry, and there's some wonderful devices out there. This is, these are just kind of my rules. This is not from any kind of papers or anything that I've come across, but just from personal experience. 100 microns at the very least is kind of pushing it right kind of in the middle of that landing zone. Which I view to be kind of like your HVID, and then add a couple millimeters, and that's probably going to put you pretty much right where most any lens that you're working with is going to really have the majority of its support there. 80 microns probably still not going to work, but potentially you could do something maybe like an impression lens, and maybe you could get enough contour in that lens and into the eye, enough precision that maybe that will keep that lens from spinning. But generally, you look for about 100 microns or more, or if you've got some kind of obstacle, something for the lens to essentially anchor down and not rotate. And then going back to the dry eye, lid hygiene, lens cleaning, all that stuff. If somebody understands their responsibility and keeping their lenses clean, their eyes as healthy as possible, they're good candidates. And if they don't, or they have significant issues there, then that return on investment, it's going to be low on their end. So again, I just recommend running that aberrometry on everybody. I think the X-Wave is a really, really great device, but it's not the only, aberrometer out there. You do want a total eye aberrometer, and there's a few, and a lot of people on the call, they probably have access to several. There's, but whatever your instrument of choice is, you really want to run it on everybody, particularly, adults of driving age. And then, I always ask everybody first, we run it on everybody. And then in the exam room, the staff always asks, do you notice nighttime glare? And I always have the staff ask, because they're just conditioned to do that. So when I walk in, I already kind of know the answer for the most part. But if they say, yes, they notice nighttime glare, then that's when I come in, into the room. I basically clarify what I mean. So when I say glare, what they generally or oftentimes hear is headlight brightness. All right. So that's more of a light sensitivity thing. So I'll be really clear. Is like, okay, what I'm talking about is, more like streaks around lights or halos. It's more the pattern of light that comes off of, a traffic light or brake lights, at night. It's as far as brightness, I can't do anything about that. So, but that's an important distinction to clarify early on, because that goes into those expectations later. Is it bothersome? Do you notice it? That is one question. Is it bothersome? Is really a different question, because everybody will generally notice it to some extent, but it really has to be bothersome. Okay, if they're going to really afterwards, feel like they really got a lot out of this treatment. And then again, right off the bat, as soon as I say it's bothersome, I explain, all right, well, we can't actually fix that for you. There's a custom way to do that in contact lenses. We teach you how to put them in. We teach you how to take care of them. Don't worry about that. They can last a long time, kind of like a pair of glasses. You get them, made right. You can have them for a while, but it does cost a little bit. And then just outline your fees in like basically one sentence, right? Most people, like I mentioned earlier, are going to say no. That's not a big deal. So like if you have an Ovitz, or you're trying to get in with those lenses, and you're like, man, I'm trying to pitch this to a lot of people, and nobody's kind of going for it. Like that's fine. It's just like if you're doing orthokeratology, a lot of us on this call also do services like that. You have to know that you're going to hear no most of the time. That's fine. Anything that's new to somebody is generally going to be, initially that reaction is going to be a little bit of some pushback, but you're planting the seed for later. Irregular cornea patients, generally they are interested in it. Okay. A lot of them are already in, rigid contact lenses, and they know their vision so much better, but, they know what you mean when you talk about glare. I notice many, if not most of them, are interested in it. Now, sometimes, they'll be interested in it and I'll have to kind of pull the reins back for them. And I'll say, all right, well, right now you're noticing a ton of that glare, but we're going to take your maps and you come back. We're going to take your maps of your eyes, profilometry maps, of course. And then I'm going to put a diagnostic lens on your eye because I got to check, what the prescription would be anyways. And I'll demo it. Once we have your prescription kind of dialed into what your vision, should be through a lens like that, I can demo the HOA for them in the room. Just, I'll have something on my digital acuity chart that has a point spread function kind of light source, but you can just stand in front of them with like a little pin light or something. And a lot of times they will be certain that they're going to want to do, this custom HOA optics, and then you put a lens in front of them, and it's just tremendously so much better that they may or may not. So I would always do that during that kind of diagnostic lens assessment and just confirm, go through the motions one more time. Like, right, you see the glare. Is it bothersome? I'm always really specific about, is it bothersome when they're best corrected through that diagnostic scleral lens. This is kind of just like a kind of decision tree here. Again, run on everybody. Talked about, is it bothersome? Demo it. I demo it on everybody too. This is just like going through the motions for me. Even non-scleral lens patients, non-contact lens patients, whatever it is. I just want them to know what I mean by the HOAs. And so I'll put up on my digital acuity chart, that little single point of light. I'll have the lights down in the room real low, just so they definitely understand what we were talking about, the same thing as far as HOAs. If the answer is no, then totally fine, no problem. We do have that technology in the office, as we're always trying to stay on the cutting edge with that. We'll just monitor for you year to year. If it ever becomes a problem for you, just let us know later. If they say yes, then you can break down like, okay, all right, if it's bothersome, let's see like how your numbers come out. All right, you're have this much coma or this much trefoil or whatever. And then patients do generally like to see that what they are seeing and what the instrument's seeing actually does match up. It's really validating. Again, like I mentioned, briefly go and just mention your fees. That shouldn't be something hidden. I'm a believer in just mentioning my own fees. A lot of people will delegate that. I think that's a little bit of some lost time. And when we talk about the challenges of everything, we talk about staff time and your time, the patient's time. I don't particularly like to do that. I just present the fees, real quick. I'm also more confident in my fees because I know what goes into all of this, right? So, the fees are the fees, and I'm not, apologetic about it. I'm sure none of you are either. So it just sometimes can be a little more powerful just coming from the doctor. That's just my opinion. All right, and they say, yeah, I'm certainly interested. Schedule profilometry fitting or your diagnostic fitting. That's how you like to do it. And if not, no problem. We understand that this is, bothersome and not quite ready for it. We'll just check you again next year. All right. So Jenny mentioned this a little bit with the optic zones. That's huge. That's probably number one, is like how to get that optic zone in the middle the best that you can. All right. There's going to be certain situations it can be, particularly tricky to do that, but we've got really good freeform lenses. I saw some of the visionary optics folks are on the call, that latitude lens. I don't have access to it, but that one looks great. I have both the eaglet and I have the Pinacam CST Pro. So I have some access to some other freeform lenses that have really worked well in some eyes that otherwise I kind of struggled with some centration. You have impression lenses, which really work great for centration, but the optic zones being in the middle, that's really, really important. The other thing, probably equally important, is essentially just rotation. So going back to a previous slide, or actually just down a couple halfway through this slide, again, this is not backed by the literature. This is strictly just my rule of thumb. If they got less than 100 microns, it's probably not going to work out. That lens is probably going to rotate. If you are super duper lucky and this person just has a lot of spherical aberration, that's their primary HOA, then maybe maybe it's okay if the lens rotates a little bit, but generally speaking, we're usually not that lucky. 150 microns is pretty good. I still, at that point, I try to do everything I can to get more sophisticated haptics on the eye. And then over 150 microns, yeah, generally pretty much anything is going to work. And now that OVITS has expanded a little bit with some different platforms, there's a lot of options for sure with eyes with a fair amount of asymmetry or toricity. Is a scleroprofilometry or a scleroprofilometer necessary? It's one of those things where the answer is no, but anybody who has one is going to tell you yes. Like, you would never want to do it without the profilometer once you've had it. It's like fitting corneal lenses or ortho-K lenses without a topographer. Like, I'm sure that it is possible. I'm sure people did it for many years, but you would never go back to doing something like that once you had something like a topographer, right? And the scleral data is no different. If you want really good results, I highly, highly recommend getting an instrument that's going to map out your sclera. Raised obstacles, they help a lot. Honestly, it's weird that the things that make normal scleral lenses easy to fit are generally like, maybe more scleral symmetry, which isn't very common, but that would technically, I guess, be an easier scleral lens to fit. Things that like pingueculas or pterygiums or blebs and things like that, that generally makes it a much more difficult scleral lens fit. But when it comes to HOA optics, or sometimes even just like multifocal optics, any kind of more customized optics, it's kind of the opposite. Those things that would be a normal, easy, regular scleral lens become very, very difficult to achieve good results with custom HOA optics. And you actually want the more irregular the eye, the better. All right, lid hygiene, hydropig, all those things, that's important too, because honestly, what's the point in investing so much time, energy, and money into this technology if you really can't get good quality vision through the lens just because of ocular surface disease and lens whitting? Specifically for the OVITS, I guess, approach, I am going to somewhat disagree with, I guess, the OVIS recommended way of doing things. So, if you're a trial lens fitter, then great. I don't do it that way, so I really don't know how that. I don't really see the point in that, to be honest. But I recommend investing in some technology that you can map the eye. So, that's really your first visit, as far as the doctor. I'm not including like the consultation or where these discussions happen, but once they decide to say yes to this technology, you're going to have one visit where you're basically going to collect data. So whether, that's profilometry data, you're going to be taking impressions. Again, the diagnostic fitting, that's where you're going to collect the data that's going to be relevant to your lens order. The rotation, if you see the lens on the eye, diagnostic fit, then it's stable, then go ahead and proceed. Again, with your profilometry, you'll know just from quantitative cord measurements, like if they're a good candidate and if they expect rotation. And then this is where I differ from OVITS. And I've tried everything, so we can talk about this, but we've had our unit, I guess, about 2 years or maybe just past it, and we've tried like everything that you can imagine. We've done it all, okay, from a workflow standpoint. Follow the rules, didn't follow the rules in different places. What I found is just order that first lens with the base markings. Don't essentially waste time with a training lens. That base markings lens, even if for whatever reason it needs a revision, you can always order a second base markings lens, but just order that first one with the base markings. That second visit is just the lens is going to be in the eye for like 2, 3, 4 hours max. So they're actually going to come in the morning, but you don't see the patient. Your staff will see the patient. Okay, so the staff will put the lens on the eye for them. They don't need to know how to do scleral lenses yet. That's for later. That's a later visit even. So the staff will just put it on for them, and then say, hey, go to work for a couple hours, go to lunch, come back after lunch, and then we'll basically take your scans. The staff will do that too, right? And then after the staff's done taking the scans, and you already got the baseline scans, you could have gotten the baseline scans when they first showed up that morning, right before you put the lens on, or if you are running the X-wave on everybody during their regular eye exams, and you would have achieved the baseline scans at that time. So that part's already been done. Really, the time with the doctor is just a few minutes. So they're going to come in, and all that you're essentially going to do is you're going to over refract, just make sure the lens is as it should be. Like I said, I'm a big proponent of putting a diagnostic lens on at the time that I take my profilometry measurements, so that I've already demoed what the HOAs really look like, confirmed that it is actually bothersome. I've already got my refractive data. So at that point, like my refraction should be very, very, close, if not spot on. And then again, with the fit, the lenses just come out really nice with this technology that we have available now. So it's not likely that you're going to really have to adjust the fit. And if you have to adjust the fit, like it should be very, very, very minimal. So minimal that it's probably not going to affect, lens centration, that type of stuff. Should be very, very close. So if fit's good, then basically you just order the HOA lens. You submit that to the OVIT's online system. If it's not so good, like I said, you just order a second base markings lens if you think that the change is significant. Staff takes off the lens. So you're only in the room for like maybe 5 minutes. Okay. Then the staff takes off the lens. Don't train them on the lens. Don't dispense that lens. In the past, we've done all of those things. It's a waste of everybody's time. Just don't. Okay. Just wait until the true final lens comes in. And honestly, patients are happier too. They just want to know, all right, when's the real deal going to get here? You let me know when the real deal is going to get here so I can then really enjoy this thing. All right, so they come in, they get training again with the staff. So their third visit to the office or the third visit in this series is also not with you. So your schedule should not really be disrupted. Okay, they're going to do that on just the staff schedule. In my office, I'm only in clinic Monday through Thursday. So we see patients Monday through Thursday, and then Fridays is essentially like an admin day for the whole office. So I don't see patients. I'm usually there, or maybe I'm not there, but it's my admin type stuff I'm getting caught up on, and the same for the staff. So they're doing their own little admin stuff. They're doing their lens application removal trainings. They're doing things, like OVIS measurements or whatever, right? Something that I don't really need to be involved in. So it is beneficial to have a separate schedule just for your staff. So now they've been trained on the lens. They're going to come back, after a few days, the next week, and this is the third doctor visit. So when we think about, some feedback that I've heard with OVITs, people feel like it's dragging on. There's too many visits. Well, there really shouldn't be. There should be basically like 3. If things are going well, like, you should get this whole thing done in literally like 3 visits, right? Your diagnostic fit, your profilometry, your impressions, if you're taking impressions that day. The second one is just, basically just to check the fit, make sure everything's good. It should take 5 minutes of your time. And then the third one, they've already been trained. They already know how to take care of them, put them in, take them out. They show up to your office. The lens is already on. They've been on for a few hours. And you're essentially just, again, you're just getting your final OVIT's X-Wave just to compare. And then you can basically, go through that dog and pony show of, hey, look how much we got. We got, 3 times reduction on one eye. We got, 4 times reduction on the other eye, whatever it is. Okay. That's really it. If any revisions are needed, because something feels off with the power or the fit in some way, like usually at this point, if the fit needs to be changed, we're talking like maybe 1 step or something in the haptic or something. It's maybe you want to drop the sag by 100 microns or 50 microns or something like negligible. It's really not going to be a significant impact to your fit. So at that point, you can just order that new lens. Then they can pick it up. They just swap them out. They can do that with the staff. They don't need to see you. And then maybe if there is that revision, then they're going to come back in just so you can kind of go through that blessing, so to speak, and kind of review the results. So there shouldn't be that many visits. And again, when we get to the discussion here in a couple minutes, I'm really interested to hear if people are having similar approaches and results, or if they're doing something quite different. Billing, anytime that you're doing something with greater value, there's an increased fee, right? So, when I say value, I guess I kind of mean like maybe like worth, to the patient, right? So it's fair, right? It's if something is a greater service, if it's a better vehicle, it costs more. If it's a better quality home, it just costs more, right? So this is a better quality scleral lens. The fee is going to reflect that increase. The time, I hope that what we just went over might shave off a little bit of time, but there probably will be a little potentially more time involved with this, especially if you have particularly needy patients or you're struggling, getting fit quite right. But if it takes more time to do it, it doesn't cost less. Like you don't need to feel bad because you weren't able to deliver something maybe as enthusiastically as you had led the patient to believe that you could, or maybe that you genuinely thought that you could. You need to charge more in case it goes that way, in case it goes that direction. HOAs is not as simple as just basic, refraction, right? There's a lot more complexity to understanding HOAs. We're continuing to learn more, and especially in the last couple of years, there's just a lot of knowledge that we're gaining in the HOA space. So there's an increased fee involved with essentially you kind of staying up to speed on all that. It's self-pay, right? So if they've got like a vision care service plan or whatever, it's this would be considered an upgrade, so they do need to pay for that. We're not going to discuss fees, of course. It probably should be sizable. As far as like self-pay, you can do that through a global fee. You can do it as an add-on. I still consider this as kind of like a separate add-on. Aberrometry is also self-pay. The code that I think is most appropriate is the 92499, which if you're in the United States and CPT codes, this is just unlisted ophthalmological service code. So it's just not specific. It's not going to be covered by an insurance. You can charge whatever you want for it, but it's probably good to have a code. It's probably good to have it on the patient's invoice. I wouldn't really recommend doing it for free. I would charge something minimal, to be honest. I mean, that's up to you, but I do a lot of screenings, whether, with the Pinicam and with the aberrometry, and, we do mammography on every patient. We do all these things that are not, retinal screenings and stuff. Like, we do all these extra things. I can't do them for free, but if you're careful about keeping the fee somewhat, reasonable, and you do a multitude of those things, then patients generally don't balk about it too much. If you're charging a significant amount for multiple things, for just screenings in which things patients may or may not be symptomatic of, that's when you can sometimes get into maybe a little bit of conflict there. Refraction, I wouldn't recommend this. I think you can make an argument for it, I suppose, because I mean, it is, I guess, doing refractive data. It's got an autorefractive component, and it is ultimately the refractive system of the eye. I think that it probably just requires more research into your state, what they view to be a refraction. It might be dependent on the payer, your contract with the insurance that might be using. To me, it just doesn't feel, I guess, quite right unless there's like a subjective component with the refraction. So I'm not sure I would do that, but would love to hear what other people are doing. And then again, there's ways to make additional revenue off of these the services just by selling other products and services, specifically dry eye and blepharitis related services.
And Dr. Wolf, I think someone raised their hand for a question on the billing page. So the question is, how can you tell which patient will be happy with just a normal scleral lens? Is this the reason why Ovis recommends a trainer lens?
Okay, so the way that I do that is I discuss what HOAs are with patients, and generally to kind of simplify, we're talking mostly about patients that are in scleral lenses or going to be interested in doing scleral lenses, regardless whether it's keratoconus, some kind of ectasia, some kind of severe dry eye, or whatever. Like this, let's assume that they're going to go to a scleral lens anyways. I will demo the HOAs binocularly, so through a diagnostic scleral lens. So I'll take the maps of their eyes. The maps will say, okay, they've got this much touristy in their eyes. I'll go grab a diagnostic lens from one of my mini contact lens kits, and to kind of match, that particular touristy, I'll put it on the eye, I'll over refract, and while I have the phoropter in front of them and I've completed my over refraction, then I open up, both sides so that they're seen binocularly, and then I kill the lights in the room, and I have a small white dot that's provided on my digital acuity chart, but you could just stand in the room with like a pen light. And then, so if you want to know, are they going to be happy or not? Well, if they are still symptomatic of their HOAs when they're binocularly viewing that target with their best corrected acuity through a scleral lens, all those boxes are checked. And if they are symptomatic and want to proceed, then I'm highly confident that they're going to have great results and be happy.
Quick comment. One way you can also check is you can take the X-ray scan over the fitting set lens. And that kind of tells you how much of a residual high order aberration is coming out of the scleral lens. But that kind of tells, how much this patient will still have high order aberration even with the regular scleral lens, and then you can.
Yeah, that's a good way to quantitatively. And we certainly, you will do that if they proceed, because you're going to end up doing that exact same thing over the base markings lens, but it doesn't always transfer to symptoms per se, because sometimes the HOAs can be kind of shockingly high, and whether it's personality or eye dominance or something else, but sometimes you'll be like, gosh, I cannot believe that this is not bothering you, but sometimes it's not. And then other times, it seems like, you do your scans and it's a very minimal amount of HOAs, and it's, you're like, I don't know if you're going to get a ton of improvement here because you're already not that high, but they are very bothered by it. So that's where I like the subjective kind of binocular demonstration a little bit more than the objective kind of quantifiable data. If you're trying to determine, is this going to be something that's going to be viewed as a success or a good ROI on their end. The summary I don't think is necessary. I'd love to just get into the discussion with any remaining time that we have.
Okay, so I just got the OVIDs literally 2 days ago, and I have not had the first patient yet, but the first patient consultation yesterday was a post-LASIK patient who is very, very, very unhappy. And he was gonna fly down to Southern California to have HOA lenses made, and then he saw my name. In any case, he is seeing 2015 OU in both eyes, but he's really, really complaining a lot. So I'm just wondering, would you take on such a patient?
Yeah, I think post LASIK patients are some of the best ones for this. I've got lots of post LASIK patients, and they have good acuities. I think there's a pretty good difference. Going back to an earlier comment, with acuities, it's one way that we use to measure vision, but I don't know how well it really translates to like how happy somebody is with the vision or quality of vision. I think Dr. Edmonds, I see him on the call. I think you've done some spatial sensitivity, but contrast sensitivity type stuff. I mean, like we've had discussions in the past about some of this. There's going to be some other objective ways that we determine somebody's vision is just not what we thought it was based on 2015. But if they're bothered by it, generally speaking, I'm really confident that they would have good results. And it sounds like maybe they haven't had their OVID scan done yet, but I'm sure you're going to see a ton. You're going to see a ton of spherical aberration. And you might be surprised. There might be a lot of something else. There might be something that sneaks in there, and for whatever reason, they got a lot of coma or a lot of tracheal. But it's going to be mostly spherical aberration. And these lenses should work great, provided for all the other things that you can get the lens to center and rotate or not rotate, and you got to kind of go through the steps, I guess, there to make sure that they're gonna be happy. And right now, you just don't have enough data, so I'd be careful what you kind of. It's that whole like under promise over deliver thing. Post-LASIK patients are going to have HOAs. In fact, post-LASIK patients can do great in OVID's HOA technology. Okay, but at that point, that's all that you know. You don't know that they are going to do great in it yet because you don't have enough information on that particular case.
Dr. Wolf, on that note, can you share with us some of the wording and terminology that you use for these patients who are kind of a maybe? Maybe they'll benefit, or maybe it might not be super successful. How do you set the expectation?
Do you mean like just at a regular eye exam, or do you mean more like somebody who's already they're kind of committed to doing a scleral lens, or either one?
Has issues, but RMS is maybe on the lower side, never done scleral lenses before, could be a good candidate because they're having issues with glare, but objectively the data is kind of borderline.
I really circle back to kind of the same thing that just works for me is I really like to demo it the best I can. So like in that discussion, I'll just be like, all right, are you and I talking about the same thing? And because, I know you hear glare and I'm saying the words glare and whatever, but are we talking about the same thing? What I'm talking about is the little weird streaks and flares that come off this light, and I put it up on the wall and I say, all right, I kill the lights. And I say, that's what I'm talking about. Like that little white circle look like white circle. The U is going to look like something a little different. If you cover an eye, you'll just notice, hey, it's a little bit different in your right eye. than it is on the left eye. But like that's what I'm talking about. And you know, if that's bothersome, we can make it better. It's custom. It costs a little bit of money. It's going to cost some time, but that technology is there. We have access to it here. It's still very new. There's not a lot of people doing this still, but it definitely works. We've been doing it for a couple of years, you know, so they know that this technology is not like brand new. Like they're not like a guinea pig. Like it's been out for a while. It's doing well. And then I just say, hey, you know, ultimately we won't know until we get a lens on your eye. And when you come in, we'll take your map, we'll put a lens on your eye, we'll confirm it, and then you can see, you know, really what I'm talking about. And then once we do that and I demo it again, like if they're somewhat bothersome, you know, bothered by it, then I will let them know is like, if you're noticing this and this is bothersome, binocularly, right? Because I don't want to skip over that. A lot of this is monocularly, like as far as the scans and we're talking about, you know, objective reviews, but none of that really matters to the patient that much. They're not observing life, driving, watching TV. They're not doing those things monocularly, right? They're doing it binocularly. So it's really important that you kind of keep in that binocular setting as much as possible. Yeah, I mean, if it's bothersome, I just tell them like, yeah, I think you're going to do great. But I always like to get those maps because I've been burned not once or twice, but like many times where I'll essentially say, yeah, this technology is amazing. And then we get the lens on their eye and I wasn't paying that close attention to if that lens was going to rotate or not. And then it does. It's at that point, like you're just chasing your tail. The patient may even like be like spinning their lens in place or something. It's just kind of a nightmare. So you really got to be careful about saying too much until you have that data, and then just say, yeah, we'll just have to wait and see. And if you're a candidate, it's kind of like LASIK, right? When people are like, hey, am I a candidate for LASIK? And you're like, I don't know. We'll have to find out. Right. So like if you have a Pinacam or something, then you can find out there. But if you don't, you have to send them over to a LASIK facility and be like, yeah, they'll tell you. I can tell you right now if you're a LASIK candidate or not, because I don't have the answer. We got to get the data. And once we get the maps, we have the data, then we'll know. So hold your horses.
Thank you, Dr. Wolf. So we have another question, follow-up to the post-LASIK patient. So this individual has a corneal specialist in town who does a lot of intacs. And even though the patient's acuity may be improved, they have a lot of complaints of glare and shadowing. Have you had a lot of success with OVIDs and post-intact patients?
Oh yeah. Yeah, I've done several intact patients with the OVIDs. It works. That's a good one. That's a good, those are generally really great candidates. Pretty much anything that's causing like irregular curvature of the cornea are great candidates. That's your bread and butter stuff that you're going to do most of the time. But yeah, like I don't see a lot of intacts in my area because we just don't have a lot of surgeons in this area that ever really did a lot of that. But you know, they certainly come in, and I had a patient yesterday who was in for his 1 year. He's an intact patient. He's in the OVIDs lens. He came in yesterday for his annual eye exam, but you know, yeah, it works great.
All right. Thank you so much for your time and energy putting this presentation together, Dr. Wolf. And thank you everyone else for joining us after work. I'm sure everyone had a long day. Feel free to email us, email Dr. Wolf. I know his email is kind of showing up on the screen there if you guys have any questions or comments or anything. All right. So see you guys all later. Enjoy the rest of your day.